As a clinician and woman who was thrust into surgical menopause following what was expected to be a partial hysterectomy, Oprah's recent Daily Show episode on menopause struck a deeply personal and professional chord with me. The experience shared by the panel illuminated the far-reaching implications of menopause physically, emotionally, and relationally for countless women. Every woman with ovaries will eventually go through menopause, a natural biological process marked by the decline of estrogen and progesterone and the cessation of menstruation. But what many don't realize, as the show rightfully highlighted, is that the menopausal transition, including perimenopause and postmenopause, can last 7 to 14 years. I recall thinking my mother went through menopause 5 times because of how long and disruptive her symptoms were. Now I know better. In my case, what began as a routine surgical procedure turned into a 5.5-hour hysterectomy to remove multiple fibroids the size of footballs. These tumors had grown into my pelvis and colon, leading to organ shutdown and emergent intervention. The surgery resulted in the removal of my uterus and both ovaries, one of which was initially meant to remain but was found non-functional. This abrupt hormonal shift launched me into immediate, full-blown menopause. The aftermath was devastating. I experienced slurred speech, memory loss, debilitating night sweats, severe mood swings, instability, including rage, 2 emergency surgeries, and blood transfusions. It was a textbook example of how unprepared our medical and mental health systems often are to support women during this transition, especially those of us who fall into the 2% with severe surgical complications. The episode tackled 3 major myths of which bears clinical significance, in my opinion. The first myth talked about hormone replacement therapy, or HRT, being inherently harmful. After my ordeal, HRT provided me with a lifeline. While there are documented risks, especially for cancer survivors like myself, the decision to use HRT, in my opinion, has to be personalized. For me, when the oral form became ineffective, a transdermal patch restored balance and gave me back a sense of self. The key is informed consent and vigilant medical oversight. The second myth is that if you don't have symptoms, you're not in menopause, and HRT isn't necessary. There's no one-size-fits-all experience of menopause. Some women have few symptoms while others suffer incredibly. The absence of symptoms does not negate hormonal changes. As clinicians, we have a responsibility to emphasize comprehensive assessment and patient education. In therapy, we're trained to rule out medical causes for emotional and relational distress, something particularly vital during this phase of life. Counseling should be part of menopause care, not an afterthought. The third myth is that women just have to muscle through menopause. This is perhaps the most dangerous myth of all. We live in a world rich with medical, therapeutic, and holistic resources. Encouraging women to silently suffer is not only outdated, it's inhumane. Seeking support isn't weakness, it's self-care. And that self-care builds the resilience needed to navigate the often unpredictable menopause journey with dignity and grace. What this episode affirmed for me is the urgent need for education, advocacy, and culturally responsive care around menopause. Women must not only educate themselves, but also engage their families, partners, and communities in understanding this transition. No woman should suffer in silence. Knowledge is power, and shared knowledge is healing. Let us collectively normalize the conversation around menopause so that no woman has to endure this journey alone.